everyone, and thank you for coming today for our first Research Nexus meeting for this semester. We have a special treat for you, as usual, as our first offering for the year, for the academic year. We have Dr. Comfort Olorunsaiye, uh, who I went to school with, doctoral school with. So we go way back. She has a PhD in health services research from the University of North Carolina at Charlotte, an MPH in maternal and child health from the University of North Carolina at Chapel Hill, and a B Farm from Ahmadu Bello University in Nigeria. Comfort taught all of us in our cohort about maternal and child health. We wouldn't have known about that subject area if she hadn't joined UNC Charlotte. She is an expert in, of course, MCH, sexual and reproductive health, and inequities and disparities, as well as implementation science. And she's going to talk about health inequities today. Before her coming to Arcadia, she had a stint with the CDC as well as the International Rescue Committee, their headquarters in New York City. She is a newly minted associate professor with tenure. So congratulations, Dr. Olorunsaiye. And without further ado, I will let you take over. Thank you.
Okay. Thank you so much, Deb. You're far too kind, and it's really a pleasure to see you again, even though it's on Zoom after close to 10 years. But yeah, so I'm glad to be here, and thank you so much for having me. So I'd like to, just jump right into it. And my presentation today is, aimed at discussing recent projects that I've done in obviously maternal child health using a health equity lens, and working with communities or populations that experience health disparities, just, to use the NIH lingo, but I like to think about them as marginalized populations that, experience different forms and intersections of oppression, for which reason, these communities or populations are marginalized. So, all right, so the study that I'm going to talk about originally started as a qualitative study, but midway through the study, we realized that we needed to collect additional data using a quantitative design. And so it's, kind of morphed to become a mixed method study. So I'm going to begin with the qualitative phase of the study. So we conducted this research generally around, when the COVID-19 vaccine was introduced and became available for the general population. So this was kind of like in 2021 into 22, and then, continued up until this summer when we collected the quantitative data. So the first phase of this study was, basically designed to explore the COVID vaccination experiences of Black pregnant and postpartum women. And in just a second, I'll talk about why we decided to focus on, this group in particular. So as we all know, COVID-19 has come to stay. But this is, a disease that has caused severe illness and hospitalization with, other outcomes. And as of, just before this most recent wave, close to 3/4 of the US population had experienced at least one COVID-19 infection. And within the overall US population, Black, Indigenous, and people of color, sometimes referred to as BIPOC, populations, experience higher rates of infection and other adverse health outcomes. And from the most recent data as of August, it was, estimated from wastewater surveillance that about 1 in 40 Americans were currently infected with COVID-19 as of August. So, to the rationale of, the whole study, we do, from available data at the time the study was conducted or, developed, most of the outcomes or most COVID-19 infections and health outcomes were concentrated in Black and Brown people. And this is largely attributed to the accumulation of social, stressors and systemic biases and discriminations and oppressions happening both historically and contemporarily, which have over the past several years and decades exposed people or communities to racial trauma, to discrimination and marginalization. But more importantly, also, we also know that underlying health conditions play a very critical role in the acquisition of COVID-19 and, the health outcomes that are associated with the infection. So we also know from health disparities data that chronic diseases are disproportionately represented in marginalized populations and communities of color, and these are known risk factors for infection and the severity and hospitalization or even mortality as a result of COVID-19 infection. So now, thinking about all of those risk factors, we then layer onto all that pregnancy. And it is also well established that pregnancy can cause or bring to the fore health conditions that could either be occurring only in pregnancy or it could also aggravate pre-existing health conditions. So this was one of our rationales for focusing on people that were pregnant or postpartum at the time that this study was conducted. But again, back to the point of, the health disparities and the health inequities that we see in communities and populations of color, we know that, with COVID-19, the mortality risk and rates were exaggerated or drastically increased for people of color that had COVID-19. And so this also against the backdrop of disproportionate rates of maternal mortality and infant mortality in communities of color. And in our case, we chose to work with Black populations. But I also want to quickly highlight here that at the time the vaccine was introduced, it was initially not recommended for pregnant people or postpartum people who may be breastfeeding. But later, as more data became available, the CDC and the American College of Obstetricians and Gynecologists recommended the vaccine based on the fact that it was known to be safe in pregnancy and in breastfeeding. So, when we think about COVID-19 vaccination rates, the data available show that, populations, again, that are marginalized on the basis of racial classification and ethnicity and other systems of oppression have lower vaccination rates compared to the national average or to other subgroups within the population. And a lot of the disparities and the mistrust and the distrust is not just because people do not want to be vaccinated, but traces back to historical experiences with the US public health services and the medical system, which contributes to hesitancy within populations that experience disparities, in our case Black communities or populations, hesitancy to seek preventative care, which could include vaccination in the case of COVID-19. So in pregnancy, I've talked about, the safety and the recommendation, but I also wanted to highlight here the intersecting systems that, contribute to the mistrust and lower vaccination rates, which could result from medical practices, the high or disproportionately high maternal mortality rates that we see in Black people. At the time this study was done, Black people were three to four times more likely to die as a result of a pregnancy or childbirth or postpartum, complication compared to the rest, to the white population in the US. So all of those intersections prompted us to take a closer look at this population and what was happening with COVID and with the preventative measure, which was vaccination that had been introduced and available for the population and also recommended for pregnant and postpartum people. So the study was conducted in Philadelphia, and this is the metropolitan, census area of Philadelphia, which includes not just the county or the city of Philadelphia, but also five other counties in southeast Pennsylvania, as well as southern New Jersey and northern Delaware. So that was the area that we looked at. And so, just to speak a little bit to why Philadelphia metropolitan area. Philadelphia happens to be a very historic city with, that has I would say, an important role in U.S. history, but it's also one of the 10 largest cities within the country, and it was a highly segregated city and still remains a highly segregated area, especially when we bring in the suburban, counties that surround Philadelphia. So, as is common with, highly segregated areas, we see high rates of poverty and socio-economic inequities within the city and its adjoining areas. And so, from the available studies and research at the time, we saw that factors that were associated with under or non vaccination for COVID 19 included living in racially segregated neighborhoods, because those areas, had very poor vaccine supplies and had very few vaccination centers, even when pharmacies were, used as vaccination centers. But also, besides racial segregation, the lower the under vaccination or non vaccination was also associated with identifying as a Black individual, and also being pregnant or postpartum, and people with low levels of education, and people who had low levels of knowledge or awareness and access to available resources, which could include healthcare resources, but also social resources. So we therefore sought to assess the COVID-19 vaccination experiences, focusing on Black pregnant and postpartum people in Greater Philadelphia, which is also the Philadelphia metro area. We wanted to particularly describe the facilitators or the motivators of vaccination and barriers across the continuum of reproductive health. And this continuum includes the preconception period, which is before people get pregnant, while they're planning to get pregnant, usually within 1 year before a pregnancy, and also during pregnancy and the postpartum period. And thirdly, we also wanted to identify acceptable ways of addressing vaccination concerns and strengthening protections for Black pregnant and parenting families within, this study. So, thinking back to the accumulation of risks and disparities and the underlying, structural and systemic, factors that contribute, and the intersecting, factors contributing to these disparities, we used a critical lens to conduct this study. And so we used the public health critical race praxis, which was developed by Chandra Ford and Collins Ahiheboa in 2010. So the framework has 4 areas of focus. But the first thing is that the framework helps to center race consciousness, racism and race consciousness throughout the research process, and also if interventions were going to be developed to address a critical research problem. So in the first focus area, they talk about contemporary patterns of racial relations, which include racism and racial classifications, and how those are expressed contemporarily but does not ignore the historical context. In phase the second focus area looks at the process of knowledge production and tries to decouple that process into who is involved in the production of knowledge, who participates in the production of knowledge, who leads the production of knowledge, and how are different voices brought into the production of knowledge. And in the third focus area, the conceptualization and measurement is how the research is actually carried out, centering race, not as a biological variable, but as a social construct. And also, it brings in other factors or other areas of intersectionality, such as social class, social and economic inequalities, gender, sexual identity, and even immigration. The framework has been used to look at immigration status as an intersecting factor. And then lastly, the action focus looks at, again, critically, how the existing inequities and inequalities can be addressed in a way that is appropriate and suited to populations that experience health disparities. So this is how we used the framework. In our focus area 1, we wanted to understand how racism operates today and how that influences pregnancy, COVID-19, maternal health, vaccinations, and overall quality of life. In our second focus area, we looked at how knowledge around maternal health and COVID-19 vaccination has been formed up to date. And you will recall that, communities of color barely participated in the clinical trials and vaccine trials prior to the introduction of the vaccine. And then in the third focus area, we wanted to know how we can better understand the intersecting complexities of all of those, different factors and systems and structures of oppression as they apply to COVID-19 vaccination. And lastly, we wanted to hear from the community and our participants how we can disrupt these inequities in a way that works for them, in a way that centers their experiences and also brings in their voice into the discourse. So, because this was a qualitative study, we used different approaches to recruit. I should also say that, before going into recruitment strategies, we had what we call community advisors. It wasn't a board, but we had 3 people with a lived experience that guided us throughout the research process and also helped us with the recruitment approach. So we had different, approaches for recruitment, but I want to talk about community outreach activities among, these different processes or approaches that we used. So within the area of community outreach, we quickly realized that, what works for recruitment generally did not work for this population because people were distrusting, not minding the fact that, the 3 of us that were members of the primary research team all identify as Black women in different, at different stages of reproductive health continuum, but still it did not mean that they trusted us, by default. So we had to use different approaches. We went to clinics, we went to doctors' offices, we went to businesses in the area. But our most successful community outreach approach was the community baby showers. And so these were, community showers that were organized by local nonprofits, by churches, and we had the opportunity to talk to people who came to the community shower and about the study and their experiences. So that was by far our most successful recruitment strategy. And this is just a picture of the three of us that are members of the primary research team at, one of those community baby showers. This one in particular was organized by a Black church just outside of Philadelphia, about 5-10 minutes away from our campus. And we went to that community baby shower on a Saturday morning and early afternoon and spent the whole day there. And, just talking to people and seeing if they were interested in participating in the study, and if to even see if they had been vaccinated at all. So our data collection and analysis, I'm skipping a lot of information simply because the time we have is limited, but we conducted in-depth interviews with consenting people between the ages of 18 to 49. We reached information saturation within 20 interviews, but we continued up until 22 to be sure that, we were not identifying any new information that we hadn't heard before. So each interview lasted approximately 1 hour. A few were less than an hour, and for probably 2 or 3 interviews, they went way over 1 hour. Interviews were conducted in person or on Zoom based on the participant's preference. And we offered a $25 gift card, Visa gift card, for participants in appreciation of their time. So again, we used the public health critical race praxis to help with the analysis of the data and how we were interpreting the themes and the sub-themes and the codes that we found in the data. So this is just a select, a selection of participants' characteristics. So mean age was about 33.5 years. And what I want to highlight here is that we ended up with, if you look at the education variable, most participants in our study happened to be highly educated and, highly educated women, all identified as women, even though, we had gender expansive recruitment criteria, but all 22 identified as women. We had a total of 28 pregnancies, resulting in 22 live births, some miscarriages and abortions, and 2 were currently pregnant. But I also want to highlight that even though most of the study participants were at least, well educated to the bachelor's or graduate level, we had about 10 people who reported that they had to, rely on public assistance during the pandemic. And most were employed also. But for insurance, we had 16 that had private insurance, I guess also in line with the levels of education and socioeconomic status. But we also still had, people that relied on Medicaid for insurance. So here I've condensed our main findings into, these 6 themes with many sub-themes there. But in the interest of time, I will not be able to talk about all the different themes and sub-themes. But the themes that we identified were centered around the perceptions of COVID-19 and its impact on their communities, and also their vaccination experience, their perception of community acceptability and motivators for vaccine acceptance. We also identify themes around the perceptions of the vaccine efficacy and safety, and ways, again, to center, the action or the focus on action in the public health critical race praxis. We wanted to hear from them what they thought were the appropriate and acceptable and culturally sensitive ways of strengthening COVID protections in the Black community. And we thought this was, important to tease out, especially because now COVID is treated as an endemic disease, almost like, the seasonal flu. And so we have seen, periods of ebbs and, of waves and ebbs in, the infection across the country. So we wanted to see what they thought was the appropriate way for ongoing support and to strengthen protections. And we also had some unexpected findings, which, were not related to any of our research questions, but as typical with qualitative research, we allowed, people to speak to their experiences, which is also in line with the framework that we used. And so I have a few quotes which I can pull up later, to illustrate some of these themes. But for now, I thought that I would move on. I said that this study later morphed it to become a mixed method study. And so based on the findings from our qualitative phase, we realized that more Black pregnant and postpartum women were unvaccinated than those that were vaccinated. And we wanted to explore more, particularly around the areas of vaccine hesitancy and building vaccine confidence. And, just to be able to support some of these findings with numbers. And at the phase that at the time we completed the qualitative study and the analysis, you'll recall this was around 2022 into 2023. We actually finished data collection in 2023. This was about when RSV was becoming an issue over the winter of 2022, and ERs were swamped with pediatric cases of RSV, and also, in terms of, the overlaps with flu vaccinations and seasonal waves. So we did the quantitative study based off of those. And also, one of the key findings from our qualitative was that there seemed to be opportunity to integrate COVID-19 vaccination with other routine maternal vaccinations. And we wanted to explore that also to see how people interacted with the three vaccines in this qualitative study. So we built on the findings from our qualitative study, which was done in phase 1. And our integration points were mainly in the methods, which included some of the research questions that we, wanted to explore more, or we wanted to, examine a little bit more. And we also, have another integration point in the results where we triangulate our quantitative with the qualitative findings. So we did a convenience sample, a quantitative, cross-sectional survey, which involved a convenience sample. We oversampled Black pregnant and postpartum or parenting people to keep that focus on the experiences of Black people. But we also recruited people from other racial and ethnic classifications across the US. So key eligibility criteria in the quantitative study included people being recently or currently pregnant. And we defined recent pregnancy as, people who reported being pregnant between July 2023 to the time of the study. We collected this data in June. So we used that 1 year period because it was in July to August of 2023 that the FDA approved the RSV vaccine for pediatric patients, children under 8 months, sometimes up to 1 year, and also for pregnant people. So we wanted to be able to, capture that experience. And so people had to be either pregnant currently or were pregnant within that period. And we also, counted people as eligible, even if they were not pregnant, if they were the parent or primary caretaker of a child less than 1 year old as of June 2024. So it was an electronic survey, self administered, and we recruited via Cint. So Cint used to be known as Lucid, a small company which specializes in recruiting samples for academic research audiences. And I have personally worked with Lucid in the past before they were bought over by Cint. So, the analysis of the quantitative part of this study is still ongoing, but I just, quickly pulled out some of the key findings or preliminary findings from the quantitative survey that we just completed this summer. And so the definitions that I've used for, maternal flu vaccine uptake, maternal or infant RSV, and COVID vaccine uptake, these are very loose definitions of low or moderate. And we used a cutoff of, 50% as moderate. So what we found is that, across the study sample, which included both Black and non-Black individuals who met inclusion criteria, flu vaccine uptake during, the period that we were asking, which was between July of 2023 and June when the survey was done, was above 60%, but it wasn't much higher than 60. It was above 50, but not much higher than 60. So we said that was, moderate in comparison to RSV and COVID-19 vaccine uptake. So for RSV, both maternal and infant uptake, each was less than 50%, somewhere around the 40s. And for the COVID vaccine uptake, that was even lower than 30%, than 40%. This was in the 30s across this sample that we recruited. But I also wanted to highlight some of the related factors that we found, and this is from bivariate analysis. We have not done, any multivariable analysis. We just did tests of association so far. And so some of the factors that were related to all three vaccines, like, people who self-reported underlying health conditions tended to, to have higher rates or report vaccination in higher proportions than those who did not have underlying conditions. We also found that self-rated health status for people who rated their health as poor or fair were also tended to report higher vaccination uptake than those who thought they were in very good or good health status. And then for the flu vaccine, those who self reported one or more disability also tended to have higher reporting of flu vaccine. And for insurance, this was an inverse relationship. For people who said they did not have insurance, they had lower rates of flu vaccine uptake. And this is interesting because we do know that for people that are pregnant or postpartum, Medicaid covers healthcare costs. But again, we don't know how much of the people know those resources that are available to them. But for maternal and infant RSV, we found that in addition to underlying health conditions and self-reported health status, we also saw for RSV that people who knew, who were aware that there was a vaccine for RSV and that had knowledge of RSV were, reporting more vaccine uptake than those who did not. But an interesting finding here is that for people who reported that they were not born in the United States, they had lower percentages or proportions of RSV uptake, which included both maternal and the infant RSV. And for the first time, we see racial and ethnic classification come into play among factors related to RSV vaccine uptake. But we also saw that for people whose providers recommended the RSV vaccine, either for the pregnant woman or for their infant, they also reported higher rates of uptake. And for COVID-19 vaccine, apart from underlying health conditions and disability, the only other factor we found in bivariate analysis that was related to vaccine uptake was race and ethnic classification. So, with all of this, I just pulled out some of the lessons that we have learned so far in conducting these studies over the last 2 years. And we found overall, both from quantitative and qualitative findings, that community resources and trusted providers enhanced vaccine uptake. We also saw that even though participants, and this is in relation to COVID-19 from our qualitative findings, even though people recognize the ongoing threat of COVID-19, and had received at least one dose of the primary vaccine series, they did not intend to receive the booster or to vaccinate their babies. Some people given had vaccinated their babies, but they were really more hesitant about the boosters. And we also saw an opportunity to integrate COVID and RSV vaccines with routine maternal vaccinations during routine healthcare seeking for preconception or pregnancy care and postpartum. So the other lessons that I also wanted to highlight in relation to community, our community approach and other research approach generally, is that, as you already know, community-based research is time consuming, and we had to revise our approaches multiple times to be able to reach the people that we wanted to talk to. And most of the time that we spent was in building relationships and trust. I've talked about this, previously, that even though we identified as Black women, at different stages of the reproductive continuum, it did not mean that the people trusted us initially. But we also appreciated the funding flexibility based on the advice of our community advisors. They did not, our first default was to provide a Walmart or an Amazon gift card, which is very convenient to administer, but they insisted on having unrestricted funds for the gift card. And with the flexibility of our funding source, we were able to provide Visa gift cards, even though it meant that we had to pay more for the activation fees. That was what the community wanted, and that was what we gave. And we also had, experiences with mentoring students in this research, which, was transformational in the words of those students. So lastly, and for our next steps, we have started the dissemination process. We have 2 papers under review. The mixed methods paper is in preparation. But looking forward, we look to convene a community forum with partners, which will be broader, to help with dissemination of our findings. And also, from the findings, we want the community to center what they consider to be the priority for ongoing support and protections within, all of the infectious disease that we see emerging or re-emerging. And based on what those priorities are, we may seek additional funding to be able to carry out those steps. And my, final slide here is acknowledgements for, our community advisors, the research participants, my co-investigators, and also our co-authors, as well as, the funding source. So I will stop sharing now and take questions if there are any. Thank you for your attention.
Thank you so very much, Dr. Olorunsaiye. We are open for questions from the attendance today, audience today.
Okay. Do you want me to stop sharing, or maybe I might need to go somewhere to find
No,
information?
this is fine. I mean, you can stop sharing and then we can see you better. I guess.
Okay, better. Okay.
Dr. Jackson has a question.
Okay.
Thank you so much, Dr. Comfort. It was such an interesting talk. We appreciate it. I do have a question about, I've never heard of community baby showers. So can you please share more about what that is and how that works? Thank you.
Yeah, sure. Thank you. So, those community baby showers, they are a very common occurrence in Black communities and communities of color, where community members come together and seek, funding and support from local businesses, non-profits to be able to give, a shower, to hold a shower for people who cannot hold their own baby showers. And so this one, we attended three actually. One was organized by a local nonprofit. Another was, by the church, and that's where the picture I showed, came from. This was a local church, a Black church, just outside of Philadelphia. And there was another one also, organized by community partners inside the city of Philadelphia. That was led by the health department.
Thank you. Very interesting concept.
Any other questions? Okay, so I have a question. So
Okay.
this is so exciting. Like I see like how you have transitioned from core quantitative to going out in the community and asking. This is like so
I
alien
know.
to our training. Like
Yeah.
if I can't emphasize enough. So I'm like so how do we, like, if we want to go into the community, and you said
Mhm.
that we have to, like, we're having advisors from the community to advise us on the methods. How do we establish, how do we find these advisors in the community? How did you do that, go about doing that?
So, yeah, I mean, I was thinking about, my work as I was putting together this presentation, and I was like, no one would believe that I trained as a health services researcher because the work I do now is predominantly population health and mixed methods or qualitative. But yeah, I think, in working with communities, the first thing that I have learned as a lesson is that you have to be part of the community. You don't necessarily have to live there. But since coming to Arcadia, even though I live within the study area, I have intentionally been part of the community, attending community meetings, um, volunteering, working with local nonprofits, because when it came to time for recruitment, we had to go to those local nonprofits that we have worked with. And one of my co-investigators, also the taller person in the picture that I showed recently, she also was she was working with our department as internship coordinator, and so she also had lots of relationships with local nonprofits. And so that was our first step. But I think, more to the point of bringing people together to the study, our advisors were really key. We didn't have enough resources to have an advisory board or, set up an advisory group, but we identified those three people when we started to develop the study, and they helped with refining our research questions. And they also helped us with the recruitment approaches, with telling us when there was going to be a baby shower, and who was hosting it and who we needed to reach out to. So those relationships, some were already existing, but we had to build new relationships. And I think it just comes from the community seeing you as someone who's vested in what bothers them, someone who recognizes that, who sees themselves as a part of the community also, and not that you're coming to help them solve the problems, but you recognize their strengths and the assets that they have within the community. Those were, I think, the biggest lessons for me, making that transition from a core quantitative researcher to wanting to do more qualitative work and mixed methods work, especially using, a community-based participatory approach.
What kind of, so from your findings, like the the major, like you see the disparities, how do you think you're going to like address those disparities? Is that a community level intervention, or do you think it's a more broader systemic or state level intervention that will solve the problem, if it can be solved, that is?
Yeah. So I think it's going to be a little bit of everything because I mean we have illustrative quotes, from our qualitative phase, like when we talked about the protections for black pregnant and parenting people and communities. Some of the things that came out were around providing more education, through trusted sources. And one person that people continued to mention in that area of questioning was Dr. Ayla Stanford, who led the consortium of Black doctors to address the vaccine inequity and inequalities within Philadelphia, which saw that Black communities had no vaccination centers, they did not have adequate vaccines, until they began to see someone who looked like them, someone whom they trusted. People were not willing to accept the vaccine or go the extra mile. So I think it's going to be a little bit of everything. But within, I mean, we are not going to prescribe any approaches for the community, which is why we're going to take these findings back to them. But from the recommendations that community members make, I see a lot of opportunity for educational approaches, disseminating accurate health education, right, around disease, around preventative care, around the safety of the vaccine, especially for pregnant people and their fetuses, which was, one key concern for most of the people we talked about, or people just didn't know how the vaccine would affect their babies since they were breastfeeding. So they talked about, providing accurate and science-backed information. So people really want to see the science behind the vaccines, behind, the approaches and the recommendations that are coming out. But there was also people who talked about tailored messages for Black people. They talked about, healthcare providers being intentional in building trusting relationships with their parent and with their patients, and also seeing that the quality of care improved for everyone, because many people felt like they didn't have good quality care compared to other racial groups. And so that's why I say that it's going to take a little bit of everything. But lastly, the Black church also came up frequently in people's approaches. And so, it's going to be both community health systems, also the local health departments, coming together to try to, create lasting solutions to these problems.
That's just yeah, it looks like a big problem. It requires a lot of time and resource to deal with.
Oh yeah.
Yeah.
It
The
does.
church is an underused resource. Remember, like when we were in school, North Carolina Black churches played a huge role in getting their congregation to get tested for breast cancer, and that brought
Yeah.
breast cancer rates down. Yeah.
Yeah, very true. And I think it's even a bigger factor in a segregated city like Philadelphia, where many people, kept on talking about the Black church, not just being a source of health education, but also the Black church being a place of hope. And that goes back to historical experiences during the transatlantic slave trade, and how the church was seen as a place of support, a place of hope, a place of lifting for people. So I think the church definitely is underutilized and has a lot to contribute here.
Any questions from the audience or thoughts? Yes, of course, Dr. Panizai.
Hello. Very, very nice presentation, Dr. Olurs. Olorunsaiye, did I pronounce it correctly? Sorry, can you hear
Very
me?
close. Very close. It's a she sound, even though there's no H.
Oh, Olorunsaiye.
Yes,
Olorunsaiye. Oh.
excellent. Thank
I,
you.
I try to get names right. And hello, everyone. It's good to be a very exciting project. I have two questions. So one, in one of your slides, I came across the word obstetric violence or obstetric violence. I I have a suspicion what it might be, but maybe I could ask you to clarify what that could be. And then my second question is, do you have any plans of following up with this cohort? I mean, I don't know what the current guidelines state, whether these women might be multiparous and they might, conceive again and again. So what would their feelings and behaviors be like reflected that they participated in this particular study? So how does that look in your plans, and what weightage would you give to that if you were to follow it up?
Mhm. Okay, so thank you for those questions. So to the first question around obstetric violence, actually that was one of our unexpected findings where, a few people talked about not just the restrictions around the time of the COVID peak when people were limited in who could accompany them. For example, when they wanted to, go for care or during childbirth and all that. But, to the point of obstetric violence, this is around the issues of maternal mortality and people of color feeling, like neglected or ignored, and their concerns were not taken seriously, right? When they felt something was not right and they were kind of just, shooed aside, like, hey, you can't tell me, what to do. And so there are several ways that, obstetric violence presents itself. It could be in such areas where people are disregarded, or people even having, obstetric procedures performed, like a vaginal, examination without consent, and like other historical practices around the eugenics movement and forced sterilization, coercive birth control for people who did not really want those methods. So it's a lot of different things that come together, but more importantly, I think all those different expressions of obstetric violence are key underlying reasons why we have the disproportionate rates of maternal mortality in communities of color, especially Black communities. And then to your second question about our next steps and continuing to work with this cohort. So assuming the community, we still remain in touch, and two of our, participants and one advisor, are working with us in interpreting our findings. And so we still stay in touch with them. Our last forum with them was in May, when we brought, the participants together to help interpret, these findings just before we launched the survey. But I think one way that people expressed to us that they wanted to remain involved was either when we were developing another study, they wanted to be a part of it, or if we were going to develop any interventions to address these problems, they wanted to be part of that core group. And I think that's one way that we intend to keep working with the core group. For the quantitative, it wouldn't be possible for us to keep, working with them, because we had to use a marketplace to source participants. But with that core group, we definitely intend to stay in touch and keep them involved. Thank you.
I just have a comment. I really appreciated your slide deck. It was very clear, and the colors and the graphics were really cool. Thank you.
Thank you. I was really worried about that. Like, wouldn't this be distracting? But yeah, thank you for that comment.
So we are having a moment of Zoom doom, but I believe if there are no other questions for Dr. Olorunsaiye, then we can, you know, because we have to a minute back, I guess, from our Wednesday.
Thank you so much. It was great. Good to
Thank
see
you.
everyone.